Hello everyone. So let us discuss today very interesting case. A 30-year-old female came to us from an outside hospital with the following chief complaints and signs and symptoms. Let us see. So this patient presented with generalized weakness for 2 months, fever for 2 days, and fever was associated with rash. She had episode of GTCS, two of such, since today morning. On further examination, patient had decrease in platelet. The report was available from the outside hospital. Decrease in hemoglobin. Patient received in a intubated and mechanically ventilated condition. On arrival, as you know, patient who comes to us with GTCS, immediately we check sugar. Immediately we do a CT scan of brain to rule out life-threatening things. So CT scan is normal. That means in most of the cases, acute ischemic stroke is ruled out. But in few cases, in the CT scan early, you cannot rule out the acute ischemic stroke. So it needs a MRI brain. But with absolutely certainty, you can rule out ICH, SAH, SDH, EDH. However, what is important in this case is she had an history of miscarriage long back. So based on these things, let us check out plan for this patient. For every patient, our first job is to frame a differential diagnosis based on the information provided. So in the beginning, patient is a young female presented with constitutional symptoms and also fever and rash. So the first diagnosis that should pop into our mind is tropical illness, or it is also called popularly systemic febrile illness. We have dengue, we have malaria, we have typhoid, we have scrub typhus, we have leptospira, chikungunya, etc., right? So this is the first differential diagnosis that should come to our mind because you are living in a tropical country. Next is GTCS. A patient who presents with GTCS independently without any other signs or symptoms. First, we have to rule out acute event inside the brain. So here, what is the probabilities? One is brain, one is systemic. In the brain, we've already discussed. It can be acute ischemic stroke, ICH, SH, SDH, EDH, etc. In the systemic part, we should first rule out urea regarding hepatic encephalopathy, sodium balance, calcium balance. Now, coming to a patient who is presented with fever along with GTCS. Here we have two probabilities. What are the two probabilities? CNS infection, non-infectious cause in CNS. So in the CNS infection part, we have two differential or rather three differential. That is bacterial meningitis, second is viral encephalitis, and third is systemic infection complicating a CNS problem. That is septic encephalopathy. What are the non-infectious cause that can cause problem in the CNS, particularly in this who is a 30-year-old female? We can have cerebral venous sinus thrombosis. We can have posterior reversible encephalopathy syndrome, PRESH, autoimmune encephalopathy. Now, a patient who is having thrombocytopenia and anemia as presenting feature, again, the tropical illness can cause all this condition, right? Also, patient can have iron deficiency anemia because she's a female. Patient may have bleeding issues, excessive menstrual bleeding or GI bleed or any kind of bleed can produce a anemia like condition. Because this patient also had a history of miscarriage in the past, plus she's a female, she's young, she presented with fever and rash, the chances of getting into autoimmune infection, autoimmune condition is very high. So what are the autoimmune condition this patient can have? This is very important. Number one, considering anemia, thrombocytopenia, fever, GTCS, patient can have thrombotic microangiopathies like TTP or HUS, right? Patient can have hematological condition like DIC or hematological malignancy. Patient had a history of miscarriage. Patient can have SLE with SLE flare, antiphospholipid syndrome, or catastrophic APLA. Patient can have hemophagocytic lymphohistiocytosis, right? And of course, there are some other condition that has to be looked in here. That is toxin ingestion. Patient can have a suicidal overdose of some of the medications. Patient can have drug overdose. So for all of us, it is very, very important to take the history very, very properly. What are the medications you are on? What are the psychological status you are on? So now you can see we have a plethora of differential diagnosis surrounding us. So now how to approach to diagnose? How to approach to reach at a conclusive diagnosis? So before that, let us line up all this differential diagnosis as I've done for you today. As you've discussed, patient can have tropical illness, patient can have viral encephalitis, bacterial meningitis, septic encephalopathy, neurological conditions like cerebral venous sinus thrombosis, posterior reversible encephalopathy syndrome, autoimmune encephalopathy. Patient can have autoimmune conditions like SLE, APLA, autoimmune hemolytic anemia or ITP, thrombotic microangiopathy like HUS, TTP, hematological like DIC and underlying malignancy, metabolic like urea, hepatic dysfunction, sodium, calcium, toxic and metabolic drugs and toxin. If patient was a pregnant patient, could be having eclampsia or preeclampsia or HELP syndrome. Of course, we have MAS, HLH and paraneoplastic syndrome, right? Focus history of taken. So take comprehensive complete history. Regarding labs and imaging, the first lab investigation that we want to do in this patient is a urine pregnancy test. If it is negative, then all the pregnancy related complications are ruled out. So eclampsia or HELP, they are ruled out, right? If it is positive, then our discussion will go in that way. In this patient although had a history of miscarriage, this pregnancy, they have done the UPT in the outside hospital, it has come negative. So patient is not a pregnant female, right? So next is peripheral blood smear. Peripheral blood smear will help us in categorizing the anemia. So for anemia, also we need to check whether any abnormal cells are there or not. We are mostly looking for cystocytes because as you've seen in our differential, we have a differential thrombotic macroangiopathy TTP. So in the TTP, thrombotic thrombocytopenic purpura, the diagnostic or pathognomic finding in the peripheral blood smear is the cystocytes, right? So we have to look it. Now we want to check a CBC, a CMP. The CMP will include LFT, KFT, electrolytes. So this will tell us two things. All the metabolic parameter we will know. CBC, we can see whether patient is too anemic or not, whether patient requires blood transfusion at this present moment or not. What is the WBC count? Is it very, very high to suggest for infection? What are the differential count? What is neutrophil? What is lymphocyte? If it is a lymphocytic, that it is a viral or tubercular origin. If it is neutrophil, it's bacterial origin. So some amount of information they will give to us in the CBC. And the CMP, all the metabolic parameter will be clear to us that patient is having a hypernatremia or not, hyponatremia or not, hypercalcemia or not, hypercalcemia or not, what is the urea level, what is the LFT status, does this patient can have an hepatic encephalopathy, right? Number 5, we require a coagulation profile. We can have three things. So if the platelet is decreased, as in this case, if we have increased INR or increased APTT, that means patient is having DIC. If they are normal INR and APTT, then this goes in favor of thrombotic thrombocytopenic purpura. If INR is normal but APTT is increased, this goes in favor of catastrophic APLA or antiphospholipid syndrome. Here we have to do diluted Russell-Viper venom test. So this is the information that the coagulation profile can give us. Number 6, because we are suspecting this patient can have an autoimmune condition, so all the autoimmune thing we have to do. For SLE, ANA, anti-DS-DNA, anti-Smith antibody and others. Also in this case, we will look for the APLA antibody, lupus anticoagulant, anti-cardiolipin antibody, beta-2 glycoprotein antibody. Because you are suspecting autoimmune hemolytic anemia also, we'll send for a direct comb test, a retic count, LDH, haptoglobin, of course stigmata of chronic autoimmune condition. We need to send ESR, CRP. You have to do a urine analysis, that is to look for lupus nephritis. To know the severity of the infection, we need to check for C3 and C4 levels. And the tropical dengue NS1 immediately, MPDA immediately. We have scrub typhus, IgM, we have leptospira IgM. These do not come positive in the first week. All these tests has to be sent after the initial test come negative, after few days of illness, right? Then we have typhoid dot IgM. This is again for the second week of illness. For the first week, we need to send the blood cultures, right? Blood cultures, sputum culture if available, and urine culture. Number 8 is, because patient presented with GTCS, we need to rule out the non-infective CNS condition. So we'll do a MRV venogram to rule out any venous stenosis or venous thrombosis. You need MR brain with contrast, and based on that we need to do a CSF study. For now in this patient it is not possible because patient is having a very low platelet level, so we have to wait in this case, but CSF study is required in this patient to rule out the meningitis or the encephalitis, and of course we need to rule out the macrophage activation and HLH. So we'll send LDH, we already sent there. We need to send ferritin, fibrinogen, triglyceride, and of course we may require a bone marrow examinations. In this case, if the preliminary reports of infections comes negative, we have to think of infection in an immunocompromised host or opportunistic infections or reactivations like HSB PCR, quantitative CMV PCR, EBV DNA per ml or EBV copies per ml. So all these infections we have to keep in mind. If our initial tests come negative, then drug history, if possible, drug level in blood, and look for substance abuse. So this is how we'll approach to this patient. So as you can see, we have delved into details while diagnosing this case. But is it necessary that all these tests we have to send immediately at the same time all the case? No. Here we have to segregate the tests. Initially, we will send some test. If they come positive, they will guide us for some other test. If they come negative also, they will guide us for some other test. So right now, how to send for the tests and investigations? This is called sequence of investigation. So in the beginning, so first is we have to send common investigations. Right? What are the common investigation we need to send here? CBC, LFT, KFT, electrolytes, ESR, CRP, coagulation profile, peripheral blood smear examination to characterize anemia and to look for abnormal cells like cystocytes, retic count because patient presented with anemia. If there is no obvious bleeding from the history, we need to rule out autoimmune hemolytic anemia in the first go. So we'll test for a DCT, we'll test for a LDH, we'll test for a haptoglobin. Of course, in the LFT, we'll find out whether there is hemolysis or not, unconjugated or indirect bilirubin is increased or not. That will also suggest or guide us towards autoimmune hemolytic anemia. Tropical infection we need to send, that is dengue NS1, malaria parasite dual antigen. And at this moment, I'll just send these two things only because see the scrub typhus, the leptospira IgM, the typhoid IgM, it comes usually positive late in the course of the disease, at least after 5 to 6 days. So in the very beginning, I'm not very keen on sending all those investigations. but obviously we'll start treating them because they have one common dog, that is doxycycline. But I will not send the investigation, because that will give me assurance of false negative value. But here for typhoid, you can send blood culture, and blood culture will be helpful for other causes also. So we'll send a blood culture, sputum culture if there is any sputum, and urine routine analysis and culture sensitivity, right? Of course, we'll do a chest x-ray. After this initial set of investigation is done, then we will proceed for more specific investigation that is obvious in this case. Right? What are they? MRI venogram, MRV, MR with contrast. Why MRV? MRV will diagnose any venous abnormality in the central nervous system. In this age group, in this patient, cerebral venous sinus thrombosis is a probability. So we need to rule out that. Why MRI with contrast? Because MRI with contrast and plain MRI, so the plain MRI is good to rule out any structural things inside the brain. Acute ischemic stroke, hemorrhagic stroke, or edema, mass effect, all these things. But when we are looking at subtle things, we need contrast. What contrast will tell us? Abnormal enhancement, which will be pretty useful for us to diagnose any inflammation, infection, neoplasm, and details of vascular abnormality. Example, vasculitis, etc. Or if there is any space occupying lesion, it can enhance that. And also it will show us the integrity of blood-brain barrier. That will also suggest us all these things. Also at this point, we need to send for the autoimmune things. We can send the ANA if it is positive. Then we'll further send for the ANA panels. For example, specifically SLE, anti-dsDNA, anti-Smith. For lupus flare, you need to send C3, C4. And here, we have to also rule out sepsis because septic encephalopathy was one of our differential diagnoses. We need to send an Procal. At this point of time, if the MRV and MRI brain suggest a patient can be having an inflammatory condition or infective condition, we need to do a CSF study. So in the CSF, what we should look for? Cell type, count, protein, sugar, LDH, gram stain. You need to check for comprehensive CNS panel. In that, all the existing pathology that can cause CNS infection will come. Also, additionally, we'll check for TB, CNS gene expert. We can send for CNS lactate to rule out any bacterial infection. We need to send for AFB stain, for fungal stain. Because in our diagnosis, we had autoimmune encephalitis, so we need to send for CSF for autoimmune panel. At the same time, you need to check for serum panel for the same autoimmune encephalitis panel. If our diagnosis is still not obvious, so all this investigation will take some time. By this time, if we are still not clear, then we will send for, by the start of second week, scrub typhus. We need to send for leptospira. Then, as I have said, HSB PCR, CMB PCR, quantitative, EVB DNA, all this. And here, bone marrow evaluation we need to do. Here, we need to check for ferritin, triglyceride, fibrinogen, whether we are missing macrophage activation or HLH or not in this case. Specifically, at current condition, if we found that patient is having an autonomic condition, we need to check for the serum antibody level, IgG, IgM, IgA, and that will help us treating the patient, monitoring our patient, characterization of the disease. So now let's see what happened to our patient. Patient had decreased hemoglobin, decreased platelet from CBC, from coagulation proof only platelet was decreased, PT-INR or APTT normal, MPDA negative, dengue NS1 negative. So in this case, DCT was negative, retic count normal, CRP raised, ESR raised. All the cultures are negative as of now. Urinary, no abnormality detected. But here in this common test, in the peripheral blood smear, we found a cystocyte. Not a cystocyte, but many cystocytes. So this proved the diagnosis from all the plethoric diagnosis to be TTP. Right? Thrombotic, thrombocytopenic purpura. Because in this patient also fulfilling the other criteria of TTP. What are the other criteria? Fever is there in this patient. Anemia is there in this patient. Thrombocytopenia is there in this patient. Renal dysfunction is not there. CNS, patient presented with GTS-CS, it is there. So 4 out of the 5 criteria is positive in this case. Also, plasmic score is one of the score that we use in this patient that also came positive. ANA came 4 plus, C3, C4 decreased. From here, it is quite clear that patient is also having SLE with SLE flare, right? Patient was given based on these two things, started on pulse dose steroid, high dose of steroid, because steroid has immunomodulatory effect, immunosuppressive effect. So if there is an autoimmune condition going on very rapidly in a very active way inside the body, pulse dose steroid will act very quickly, very potently to seize the disease process. But absolutely we have to show that patient is not infected. So in this case, Procal was less than 0.5. So patient had no infection. Cultures are negative. And patient was on empiric antibiotic. Gave pulse dose steroid to this patient for the first 3 days. At the same time, because cystocyte and plasmic score and TTP scorings are positive, we started plasmapheresis, plex. So as the plasmapheresis started, we gradually tapered the steroid dose. At this point of time, other autoimmune panel report that came in our patient, which is positive for SSARO and anti-RO52, both are positive. And both are positive in two scenarios. One is SLE and another is Sjogren syndrome. So in this patient, the history is not suggestive of a Sjogren syndrome. So our diagnosis of SLE is proved here. And because patient presented with an acute condition with decreased C3, C4 count, patient is also having SLE flare. So considering all these things, with flex, we started rituximab. As you know, rituximab is a CD20 positive B cell inhibitor. So it depletes the B cells. It modulates the immune response, right? So before starting rituximab, we need to check what they call as, initially I told you, serum antibody levels, especially in this case IgG level. Because when you are giving plasmapheresis to a patient, what the plasmapheresis will do? It will remove the circulating autoantibodies. It will not stop the process of creation. So for that, we have to give rituximab. Now, because rituximab works on the B cells specifically, so there should be a proper washout time before giving rituximab in comparison to Plex. So if I am giving Plex right now, I should not be giving rituximab just after the Plex, because the Plex has removed the B cells from the system, circulating autoantibodies and other things. So if you give rituximab at this time, the efficiency we cannot measure because there is no B cells to work upon by the rituximab. So a minimum of 24 hours of, it's called washout time, is required before starting rituximab. Otherwise, the effect of rituximab we cannot judge, we cannot measure. So we will check serum antibody level, we'll give a washout time of 24 hours, then we start rituximab, then follow on in these antibody levels. If it is decreasing, then rituximab is working. But we have to prevent hypogammaglobulinemia, right? And this can predispose the patient to further infections. And gradually with this treatment, patient became better and she was shifted out. I must say all of you, when we started the pulse dose steroid and the first episode of plasmapheresis, after that patient drastically improved, extubated from the ventilator, she's conscious, well oriented, but her bicytopenia continued to exist. Then we thought there is some autoimmune condition that is actively going on, that is being not taken care of by the plasmapheresis alone, because plasmapheresis alone only remove the circulating autoantibodies. So we need something very, very specific. What is that specific thing? We gave rituximab to our patient and patient improved gradually. So this is how we dealt with a very serious case, very complicated case. Here you need the help of different disciplines, like for example, rheumatology, general medicine, critical care medicine, hematology, infectious disease. We need to call them and take help, sort opinion, then treat this kind of patients, right? In the next time, I'll come with another case, very, very interesting case. Stay tuned.